Good afternoon, everybody, and welcome to our webinar. I want to thank you all for joining us today. My name is Nicole Smith, and I'm the Benefits Education Specialist here at Flex, and I oversee all of our educational efforts for insurance producers, employers, and plan participants. First up, I want to just cover a few housekeeping items. We do have all of your phone lines and microphones muted, and they will stay muted for the entire webinar. But if you have questions at any time during the presentation, you can use the Questions tab on your webinar control panel to send them in to us, and we will answer as many questions as we can at the end of the webinar. Our webinar today has been pre-approved for one general HRCI recertification credit and one SHRM Professional Development Credit, or PDC. In order to qualify to receive credit, you must remain on the webinar for the duration of the presentation. For those of you that do qualify to receive credit, we will follow up with you via email within the next 2 to 3 business days, and we will send you certificates of completion that contain the course numbers for both HRCI and SHRM. We have also uploaded a PDF copy of the slides, and you can find that in the handout section on your webinar control panel in case you want to print that out and take notes or follow along as we go. I do want to take just a few minutes here to talk about Flex and who we are. We are Flexible Benefit Service Corporation, otherwise known as Flex, and we are located in Chicago, Illinois. We've been around for almost 30 years now, founded back in 1988. And we have 2 primary business divisions. The first is our consumer-driven accounts and compliance services. In this capacity, we offer FSAs, HSAs, HRAs, commuter plans, as well as compliance services like COBRA administration, ERISA wrap document services, and non-discrimination testing. Our products include integrated debit cards, automated claims technology, a participant portal and mobile app, educational resources, and a whole lot more. We do have clients nationwide with more than 3,200 employer clients and over 200,000 plan participants. We are also a general agency or insurance wholesaler, and in that capacity, we offer concierge-like services for independent insurance producers in the group, individual, and Medicare marketplaces. As a GA, we provide assistance with sales, service, marketing, and other business processing functions. To learn more about Flex, you can visit us online at www.flexiblebenefit.com. Our presenter today is David Lindgren. David is a senior manager here at Flex, and he oversees our compliance and public affairs department. He brings 15 years of experience to this role. David is a subject matter expert in the areas of ERISA, HIPAA, cafeteria plans, healthcare reform, and various employee benefit programs, including consumer-driven accounts that incorporate health reimbursement arrangements, health savings accounts, and wellness programs. I'm going to go ahead and turn it over to David now for the rest of your presentation.
Thanks very much, Nicole, and welcome everybody to today's webinar. I hope you find it very informative and educational today, and I think there'll be hopefully a few new things that you'll pick up on that you may not have been aware of before. And just going to go ahead and start with a quick overview or agenda of what we're going to cover for the duration of the remaining hour that we have. So we're going to start really talking about the current state of the Affordable Care Act and what's been going on in Washington with Republican and Democratic politicians, both those trying to make efforts to repeal the Affordable Care Act as well as those that are trying to maintain many of its provisions. And we're really then going to get into current consumer-driven account regulations, or the acronym that we use here in our office for that is CDA, and really how the Affordable Care Act impacted the consumer-driven accounts. And once we get through that, we're going to talk about some trends, really what's going on in the world of flexible spending accounts, health savings accounts, health reimbursement accounts, and even some of the commuter-based plans that are available, not so much on the healthcare side of things, but still a tax-free account that's available to those who either use mass transit or have to pay for parking to get to work. Then we're going to talk about some of the proposed changes to consumer-driven accounts and whether or not those might have a chance at actually becoming law at some point down the road, and how that might impact consumer-driven accounts going forward. As Nicole mentioned, if you do have questions, please go ahead and type those questions in. She'll be trying to answer as many of those as she can during the course of the presentation, and we'll try to wrap up the end with some of those over the phone here, answering those questions. So let's really start with a high-level overview on the current state of the Affordable Care Act, or as the media likes to call it, Obamacare, and that's really how we reference it today in most of the conversations that we have. But when we talk about the Affordable Care Act or Obamacare, I think a lot of people automatically assume that it's very limited in terms of the market segments that it's impacted. Really a lot of conversations about those health insurance marketplaces, also known as exchanges, where people that don't have access to employer-sponsored coverage or don't have access to government-based coverage can obtain an individual health insurance plan that may be subsidized in the form of reduced premiums and or reduced out-of-pocket expenses. And a lot of people also associate the Affordable Care Act or the Obamacare law with the Medicaid expansion, where about 2/3 of the country expanded the eligibility requirements for those who could qualify for Medicaid, ultimately increasing the total number of people who have coverage through the Medicaid program. And really, I think that's what gets most of the media attention. And I'm sure many of you on today's webinar are aware that the Affordable Care Act, ACA, Obamacare, again, whatever you want to call it, really does have a far more wider-reaching impact. Most certainly it does have impact to employers as well as the group health plans that they sponsor. It expands and has provisions that impact hospitals and pharmaceutical manufacturers. It even impacts people that are in the tanning salon business. So really a far-reaching and wide-stretching law. And I just thrown in about 25 or so provisions to really make that case or prove that point. And also want to make those of you aware that while the Affordable Care Act did not create consumer-driven accounts like FSAs, HRAs, or HSAs, it did most certainly include provisions that either directly or indirectly impacted those accounts, and that's going to be a large focal point of our presentation today. And when we talk about the Affordable Care Act and its current state, really I like to say the current state really depends on who you ask. For some people or for some organizations, it seems like the Affordable Care Act has had a positive impact, and for others, it seems like it's been the exact opposite. It's been more of a negative impact, or there's been a lot of administrative requirements that have given the perception of a negative requirement. And really, from a political standpoint, when we take a look at folks in Congress and what their position is on the Affordable Care Act, and we take a look at the Republican side of things, most of the Republican leaders are generally going to tell you that this law is failing and it needs to be repealed, and it needs to be repealed fast. While they have been saying that, and they have been saying that dating back to March 23rd, 2010, when the ACA was first implemented, they have not succeeded in repealing the Affordable Care Act, at least as of today, they have not. So all of the substantial repeal efforts and bills that have been introduced have not been able to get through both chambers of Congress. So the ACA, as it stands currently, still continues to be the law of the land. Well, when we kind of flip the coin and take a look at the Democratic side of things, those political leaders are generally going to tell you that the law is working. There's just some parts of the law that may not be working as intended, in particular those exchange marketplaces or those individual marketplaces. And as I already alluded to, really each business or individual might be impacted uniquely or differently. And in some instances, it may impact you in one way personally differently than it does professionally. So again, really depends on who you ask, what their perception is on the law and its success or its failure for that matter. And I just want to take one quick moment to explain the process in the event you aren't aware of the process and really kind of how all the lawmaking and rulemaking works when it comes to, for that matter, any legislation, but in particular healthcare legislation, that being the Affordable Care Act. And really the first thing that happens when we're dealing with a law is that Congress passes a law, so it goes through either the House or the Senate, and then the other chamber has to subsequently pass the bill, and ultimately that bill gets into the president's desk to either sign into law or veto that bill. And assuming that that bill does get signed into the law, that is the legislative guidance. That's really the actual language of the law, where we can quite simply take a look at that bill or that law and really point our finger at exact text that's going to tell us very specific requirements and how that impacts a group health plan or an employer's requirements or a consumer-driven account like a flexible spending account. But oftentimes, and really with most laws that we encounter in the healthcare space, that legislative process happens first, and then there's a regulatory process. So you have different government agencies. Most of the time when we're dealing with healthcare-related benefits, that's going to be the IRS, which is a part of the Department of Treasury. We're going to have the Department of Labor involved. Oftentimes, there's a division in the Department of Labor known as the Employee Benefits Security Administration. And then we have HHS, which is the Department of Health and Human Services, and oftentimes a sub-agency of HHS is CMS, which is the Centers for Medicare and Medicaid Services, that get involved with regulatory guidance. So what you have happen there is you have some attorneys or compliance folks that work within these agencies, and they take a look at the actual law, and they issue secondary guidance or regulatory guidance, as we call it, and they tell us how the specific law applies to various benefits or various situations. So I like to refer to this as after-the-fact guidance or interpreted law, where these agencies are more or less answering the what-if questions, or how does a particular law impact a consumer-driven account or a dental plan, for that matter. I like to use the 90-day waiting period as an example. We can point right to the Affordable Care Act and see that a 90 calendar day waiting period is the maximum waiting period that can apply to group-sponsored health insurance. Well, we had after-the-fact guidance then that came into place and told us, well, how does that 90-day waiting period apply to other benefits like HRAs or FSAs or dental plans or vision plans? So I just wanted to explain that process to provide some clarity, because some of how the consumer-driven accounts were impacted were from legislative guidance, and then some of that came later down the road through regulatory guidance. And the most recent action, I'll call it, in Washington, really I've broken into three buckets. What have the Republicans been working on? What have the Democrats been working on? And then what sort of bipartisan work has been going on? And the most recent bill that was introduced to repeal the Affordable Care Act, or at least significant portions of the Affordable Care Act, was spearheaded by really two senators, Lindsey Graham and Bill Cassidy. And that was taken up as recently as up until last week. And really it came down to Republicans could not get enough mutual consensus agreement within their own party to step forward and pass a bill that would repeal substantial parts of the ACA. So right now that bill is really off the table and has been shelved for the time being. Then also just the other week, Senator Bernie Sanders had introduced a bill that some people are now referring to as Bernie Care. And Bernie Sanders has really been spearheading and championing healthcare reform efforts that take a Medicare for all type of approach, or more of a universal healthcare-based system where the government would be the main provider of healthcare. When I say healthcare, really the health insurance portion of healthcare for most, if not all, of the entire country. And this has really been an effort that he's been working on his own for the past several years. But when he introduced this bill, he actually had 16 Senate Democrat co-sponsors really on board with supporting this approach. And it's unlikely that Senator Sanders' bill will have any chance of becoming law under the Trump administration. But now it seems that at least some Democrats are supporting this type of system, and this could be a really political campaign approach that some Democrats are going to be supportive of going forward. Not all of the Democrats think our country is ready for that type of system, but at least some of them, I think much more than what was originally anticipated, are supporting that Medicare for All type of approach. And really, right now, what's going on is some conversations. They've been on and off between some Republican and Democratic senators, in particular Senator Alexander and Senators Murray, and they're looking at what I'll call a short-term, almost Band-Aid type of bill that really focuses on trying to stabilize the individual and exchange marketplaces really through 2018, if not into 2019. And at least according to different media outlets, they seem to be getting closer at some bipartisan agreement. Ultimately, what will be included in that bill, to the extent it does get passed, is really yet to be determined. But that's really there's no formal bill that's been released yet, but at least the conversations seem to be progressing, and that seems to be right now the only thing that has a chance on the healthcare side of things of really getting passed from now through the end of the year. That, in addition to extending funding for the CHIP program, which is also referred to as the Children's Health Insurance Plan. That funding actually expired at the end of last month, and there are some talks about renewing that funding. Could be potentially a bill on the table as early as this week. So that kind of gives you what's going on with the Affordable Care Act, or Obamacare, really from a legislative regulatory standpoint, and what bills are or are not, for that matter, being discussed. And just want to talk about health insurance in general, in particular on the group health plan side of things. This isn't isolated to group health plans, but really that's our core focus today is around consumer-driven accounts and group health plans. And really, it's not a surprise or a shock to many of you to hear that premiums have been rising, and they have been for several years, and premiums increasing year after year really predates the Affordable Care Act several years prior. So this isn't anything new. To combat some of those rising premiums, many employers, or even individuals for that matter, have looked into raising deductibles and raising out-of-pockets. Those premiums and out-of-pocket expenses have an inverse relationship. Generally, higher premium plans have lower deductibles, and lower premium plans have higher deductibles. And for many plans, due to various provisions of the Affordable Care Act and some of the different rules and requirements, the ACA has accelerated premium increases or the rise of deductibles and out-of-pockets. At least to some extent, that trend has been accelerated. And I came across some statistics. There's a survey that really Kaiser out of the West Coast in California spearheads each year of employer-sponsored health plans. They look at employer groups of all sizes, from as few as 3 employees to as many as several thousand, up into the Fortune 500 businesses. And really, they put out a number of different statistics in that survey or that report that they compile from the results of their surveys. And I'd just like to point out where we're at today from an average perspective. And as you can see, regardless of what plan type we're dealing with, whether it be an HMO, a PPO, a POS, which stands for a point of service plan, or a high deductible health plan with a spending option. In our world, we again like to use the CDA or consumer driven account acronym. You can see premiums are really rather high for some organizations. The cost of health insurance is the second largest expense outside of payroll. But regardless of where that falls into your expense category, we do know that premiums are high. We're not sort of trying to hide from that statistic. We're just trying to share some relevant information from you. If we take a look at all plan types, single-only coverage on average is more than $500 per month. And if we're taking a look at family coverage, that's more than $1,500 a month. And when we annualize that, that's more than $6,000 a year for single coverage and $18,000 a year for family coverage. And this next chart also comes from that Kaiser survey from 2016, and really shows the breakdown of different plan types that are being enrolled in by employees. And what I really like to focus on in particular is this quadrant really in the bottom right-hand side of the screen. So you'll see my arrow kind of pointing at these darker navy blue colored charts or line graphs, I should say. And that right there is showing what the enrollment is based on these surveyed employers into a high deductible health plan that is coupled with some sort of consumer driven account. And as you can see, those high deductible health plans are really growing in terms of the number of employees that are electing that type of coverage. So as it stands today, or at least as of last year, or the end of last year, there's somewhere around 3 out of 10 employees are selecting coverage through a high deductible health plan. So really picking up some traction. You can see those numbers aren't decreasing, but rather increasing. And that trend is expected to continue to rise for the foreseeable future. So let's migrate on over to some current or the current consumer-driven account regulations. Again, some of these we can directly pinpoint our finger on in the Affordable Care Act text, and others came from secondary guidance from either the IRS, Department of Labor, or Department of Health and Human Services. And really want to talk about how that Affordable Care Act directly impacted each of these three accounts, consumer-driven accounts: FSAs, HRAs, and HSAs. So going to start with the flexible spending accounts, and really the Affordable Care Act impacted health flexible spending accounts. Some of you may be familiar with dependent care flexible spending accounts, which are sometimes called dependent care assistance programs, and those were not impacted at all, either directly or indirectly, by the Affordable Care Act, but the health flexible spending account was. And that health FSA is the account that allows employees to set aside money to pay for out-of-pocket medical expenses with tax-free dollars. And within the context of the Affordable Care Act, there was a direct impact. And that direct impact, I think the most prevalent one, or the most recognized provision that the Affordable Care Act had on health FSAs, was that it limited the maximum employee salary reduction contribution to $2,500. That number is indexed for inflation, and for the 2017 plan year is actually $100 more. It's $2,600. And prior to the Affordable Care Act, the employer got to decide what the maximum employee salary reduction contribution could be. Now, that was a provision that was directly in the Affordable Care Act, but the IRS subsequently said, hey, you know what? Now that there is a cap, we're actually going to offer a new provision at an employer's option to implement with their health FSA. And that being that indirect provision was employers now can optionally have up to a $500 carryover provision for unused funds. So no longer have to deal with the use it or lose it provision where funds are forfeited. And the reason the IRS came out and said the $500 provision was okay was because prior to the Affordable Care Act, the IRS was concerned with people deferring compensation when employers had very large contribution limits where employees might want to pre-tax dollars and sort of bank those over from one year to the next, and that was something the IRS was trying to prohibit, so they didn't allow carryover. But now that there is a federal cap today, and that cap is low enough in their mind where they feel, hey, you know what, people aren't going to defer compensation and delay when they had to pay taxes, or at least that's probably not how most people are going to use their health FSA. So we're going to allow up to $500 to be carried over. And that really has now become the most popular provision that's being added or amended to existing FSAs. Now, another provision that impacted health FSAs directly by the Affordable Care Act was that over-the-counter drugs, things like Tylenol and NyQuil, they remain an eligible expense, but in order to be an eligible expense that can be reimbursed out of your health FSA, they do require a prescription from a doctor to make that an eligible expense. And a couple regulatory provisions or provisions that came out after the IRS and other agencies interpreted the Affordable Care Act law, these regulatory provisions came out and said that a health FSA must be a benefit that is part of an employer's cafeteria plan or their Section 125 plan. Most employers already had that as part of their cafeteria plan, so not a whole lot of impact there, but some employers did not. It was a benefit offered outside of the cafeteria plan. And if that is the case, based on the regulatory guidance that was issued, it says your health FSA cannot impose any annual dollar limits on EHBs, which is essential health benefits, meaning you have to, as an employer, be reimbursing those employees with unlimited annual limits, which is not the intent of an FSA, which has a statutory cap. So really you want to make sure that if you haven't done so already, you're checking your cafeteria plan documents to make sure that health FSA is a part of that cafeteria plan. And then another regulatory benefit was that health FSAs must be considered, an industry term, an accepted benefit. And in order to meet a definition of an accepted benefit, it says the only health FSA participants can be those who are offered a medical plan by the employer, one that meets the requirements of the individual mandate or is called minimum essential coverage. And if the employer is going to make contributions, then the employer contributions are limited to the greater of $500 or a dollar-for-dollar match of the employee's salary reduction. And if you meet those two requirements, then your health FSA will be considered an accepted benefit, and you'll be good to go there from a compliance perspective. But if not, for example, you offer the health FSA to part-time employees who are not eligible for the medical plan, then the regulatory guidance says your health FSA now becomes subject to many of the Affordable Care Act market reforms, such as having to cover preventive care at 100% with no out-of-pocket cost to the member or the participant. And we know that's really not how health FSAs are intended to be designed or how they're intended to work, but the IRS and other regulatory agencies say that's how your FSA is supposed to work if it's not an accepted benefit. So going to want to double check again there to make sure your health FSA is meeting those two requirements to be deemed an accepted benefit. Now on the HRA side of things, or the health reimbursement side of things, really wasn't much of any direct guidance in the Affordable Care Act that impacted HRAs, but also through regulatory guidance, the agencies looked at the rules and applied them to HRAs, and out of that, the most significant guidance really told us how HRAs have to be designed for plan years beginning on or after January 1st, 2014. And really, that led us to conclude, or let the regulatory agencies to conclude, that there's now 6 types of HRAs that can be offered. The most common type of HRA is one that we refer to as an integrated HRA, which is one that is typically tied to a medical plan, oftentimes reimbursing a portion of deductibles or copays or out-of-pocket expenses. But to meet that definition of integrated, the participants have to be covered by the employer's group health plan. Former employee HRAs are also one of those HRAs that are still okay to offer. Oftentimes we call these retiree HRAs, where the only employees, or I should say the only participants, are retirees. And oftentimes those HRAs are structured to reimburse those retirees for things like Medicare premiums. Dental vision HRAs, those are HRAs that only reimburse dental or vision expenses. Pretty straightforward there. The small benefit HRA is one where the maximum annual reimbursement is no more than $500. It can only be made available to employees who are also offered a group health plan by the employer. They don't have to be enrolled in it, but they have to be offered it. And there can be no carryover provision with the small benefit HRA. The spend down HRA is not one that a employer can offer newly to employees, but this would be an HRA that was in force prior to 2014, may not comply with today's standards of the requirements of an HRA, but there was some accumulated balance that remained in that HRA, and the IRS says those participants on that HRA can continue to have access to those funds, and they can continue to spend down those funds until they're exhausted, but no new funds can be contributed to those, or no new participants can be offered the spend down HRA. And then the small employer HRA, this is actually something that came out of a different law, one that was passed at the end of 2016. It was included in the 21st Century Cures Act, so this was an indirect impact of the Affordable Care Act, but actually came about through that 21st Century Cures Act law. This is something available to employers who are not subject to the employer mandate, generally less than 50 full-time equivalent employees, and they don't offer a group health plan to their employees, but they want to reimburse those employees for individual health insurance premiums or out-of-pocket expenses. Those are now permissible as of the beginning of this year. So that's really our impact primarily on the HRA side of things. With health savings accounts, not a whole lot of direct impacts there with the Affordable Care Act. Really two main things came out of that. First, with an HSA, if a HSA account holder so chooses, they can use funds in those accounts for non-qualified expenses or things that aren't considered medical expenses. But if they do that, they're subject to taxes and now a 20% penalty as a result of the Affordable Care Act. Prior to the Affordable Care Act, that was a 10% penalty, so a slight increase there. And then just like with the health FSA and the requirement to have a prescription for over-the-counter drugs to be an eligible expense, that also applies to the HSA, and it does, I should take a step back and say, it does apply to an HRA also, to the extent an HRA allows for over-the-counter drugs to be reimbursed. So those are your primary consumer-driven account impacts, mostly from the Affordable Care Act or regulatory guidance that followed after the passage of the Affordable Care Act. So now I want to focus really just on some trends. So we have sort of a update as to what happened over the recent couple of years with FSAs, HRAs, and HSAs, but really what's going on, which accounts are people enrolling in, and how are things really progressing with these accounts. And this shows you really how many people have an HRA, HSA, or FSA, and then summarizes that into the total accounts and gives us some projections of where we're expecting these accounts to be in future years, going all the way up to 2020. So if we take a look at 2017 and where we're expected to finish the year, about 15 million people are covered by an HRA. About 21 million people are covered by an HSA, and about 28 million covered by an FSA, or health FSA for that matter, giving us around 66 million people in the country covered by one of the three consumer-driven accounts. And if you take a look at what's expected to happen going into 2018, 2019, and 2020, you can see all three account types, as well as the total aggregate number of accounts, is expected to increase with an estimation by 2020 that 90 million people will be covered by a consumer-driven account. And to put that in perspective, somewhere about 177 million people are covered by an employer-sponsored group health plan today. That means that roughly 1 in 2 employees are going to be covered by one or more consumer-driven accounts come 2020. And one thing I did want to point out that in 2020, right there, that number 34.5 million, that's the total number of people that are expected to be covered by a health savings account that year. That's going to be the year where the number of accounts that people have with HSAs are expected to be the leading CDA account type, surpassing flexible spending accounts, which have been around for approximately 40 years. So really HSAs becoming the more popular option for a number of different reasons. But just wanted to point that out, that just within a few years, HSA is expected to be the leading CDA in terms of account type. Now, if we take a look at total spend out of consumer-driven accounts, really, how much money is being either directly paid or reimbursed out of these accounts to pay for out-of-pocket medical expenses. Really, in 2016, about $66 billion. And over the next few years, we're expected to see the compound annual growth rate year over year increasing at a rate of about 11%, ultimately by 2020, putting us at over $100 billion in payments or reimbursements out of these various consumer-driven accounts. So we can see that accounts are growing in terms of numbers, but they're also growing in terms of total spend. So really a dual effect, or a dual impacting effect. And this shows that that total spend broken down by account type, both in dating to last year, to estimations for current year, leading up to estimations for 2020. And as you can see, the compound annual growth rate is positive for all three consumer-driven accounts, averaging 11%, but the highest compound annual growth rate is with those health savings accounts or those HSAs. And I do want to point out that estimated for this year, 2017, while HSAs won't lead the way, or are not expected to lead the way in total account types, they are expected to lead the way in total money spent, or total money reimbursed or paid out of those accounts. So again, all accounts are growing, but HSAs really seem to be leading the way, or leading the path amongst the various consumer-driven accounts that are available. So just to sort of summarize the trends, whether we're talking an FSA, an HRA, or an HSA, they're all expected to grow in terms of account types as well as total spend. Obvious reasons for that are more and more employers are offering high deductible health plans, and more employees are enrolling in those plans, generally because of lower premiums. And this is really directly fueling the growth of consumer-driven accounts, naturally, because those accounts give employees the ability to be paid or to be reimbursed tax-free for those out-of-pocket medical expenses. And as I've already reiterated and made a point, HSAs are expected to overtake FSAs as the most popular consumer-driven account, whether we're talking account type or total spend. And also wanted to point out, though, that HSAs are being used more creatively, partially because of the flexibility that the rules and regulations have around the CDAs or the HSA account itself. And just want to dwell on one of those points a little further and why that is. And that being, unlike FSAs or HRAs, HSAs are really treated and regulated more like a financial account rather than a group health plan. And the thing I wanted to take away, or the point I wanted to have taken away from here, is you're starting to see HSA dollars actually invested. The flexibility of HSA accounts do give employees the ability to put some, if not all, of their HSA funds into publicly traded investment vehicles like stocks, bonds, and mutual funds. And that's something that's unique to HSAs that does not apply to FSAs or HRAs. And you can start to see that, now we're seeing into the billions of dollars of money that HSA account holders are starting to invest. And that growth rate really is expected to occur year over year into the future. Right now, this year it's estimated that somewhere around $7.3 billion of HSA funds are invested somewhere in the market. And again, that's expected to grow next year and into the following year and years moving forward. So that being said, one of the main takeaways or unique features of an HSA and how it's being used creatively is saving for out-of-pocket expenses in retirement. Fidelity Investments puts out a stat each year, and that stat for 2017 is that the average 65-year-old couple that retires this year is expected to incur somewhere around $275,000 in medical expenses. Part of those medical expenses are the cost of their Medicare premiums. And HSAs can be used tax-free to pay for any Medicare premium other than a Medigap or a Medicare supplement plan is also the other synonymous term. So they can be used to pay for Part A premiums if there is one, Part B premiums, Medicare Advantage premiums, or Medicare Part D premiums. And also, once somebody reaches age 65, that 20% penalty that the Affordable Care Act has for non-qualified expenses, that goes away if somebody uses their HSA funds for a non-qualified expense. Now, ordinary income taxes will still apply, but there is no additional penalty. So you really can almost treat those funds like a 401k type of fund. But also unique with the HSAs is that there's not any mandatory distribution that normally applies to other types of retirement accounts. So you truly do have some people starting to think about how you can use the HSA as a retirement vehicle to save down the road. And another unique attribute of HSAs is that account holders can pay themselves back for unreimbursed medical expenses that were incurred in previous years. So let's just assume you had an HSA for 20 years and you put money into that account each year and those funds rolled over year after year, but you never touched those funds. You used another asset or a checking account, whatever it may be, to pay your out-of-pocket medical expenses. Well, you can add up those out-of-pocket medical expenses you paid out of your other accounts year after year after year and total that up for that 20-year time period and then reimburse yourself at a later date, 20 years down the road in this example, tax-free for all of those previous incurred out-of-pocket medical expenses. So truly giving you some great flexibility with how you might use your HSA or think about using it in the future. Really unrelated, this is taking a little bit of a shift, unrelated to HSAs and saving for the future, but sort of taking a look at how the consumer-driven accounts as a whole, whether we're talking HRA, FSA, or FSAs, have evolved over the last 7 or 8 years, have really evolved largely because of technology. I can remember, it just seems like yesterday where you'd have to fill out a manual form and staple receipts to it and mail it in or fax it in just to get reimbursed. And really those days, those options are still available if that's what somebody wants, but the way that technology has evolved has really made consumer-driven accounts much more modern and much more consumer-friendly and much more friendly to the plan administrators and the HR professionals that help to support and implement these benefits for their employees. But debit cards are available for most of these account types, so you don't have to wait to get reimbursed for a medical expense. Mobile apps are available. If a receipt has to be submitted, you can take a picture and upload that receipt for reimbursement or check account balances. Many vendors out there have direct claim feeds from insurance carriers, so no paperwork has to be submitted. That carrier or claim feed comes in from the insurance company, automatically prompting a reimbursement. Really, there's pay a provider options that allow for almost like online bill payment to a doctor or a hospital. Most people have smartphones in some capacity, and they can receive the text alerts or email alerts. And there's a wide variety of reporting that's available primarily to plan administrators that can help them understand how their accounts are being used. So again, really makes both the participant and the plan administrator's experience much better than it was even just 5 or 6 years ago. Now, some of the proposed changes to consumer-driven accounts. And this is just really some high-level information here, but most certainly some important information. And this is really generally speaking what the Republican leaders in Congress have proposed in previous bills, and really taken away maybe 4 or 5 key points from there. But pretty much all of the repeal bills, there were several versions of them that have been introduced over this past year. Really aimed to do 4 or 5 different things. The first, from an FSA perspective, was to eliminate that ACA required $2,500 index cap and go back to the days of allowing the employer to establish what the maximum reimbursement or the maximum contribution could be. Eliminate the requirement that a prescription is necessary to make an over-the-counter drug an eligible expense. There's been several attempts in various repeal bills to increase the HSA contribution limits, and also to make HSA eligibility easier. As an example, today Medicare Part A disqualifies a person from being HSA eligible. Some of the proposed bills would allow Medicare Part A to preserve HSA eligibility. And then some of the repeal bills would attempt to eliminate what we call some of the HSA glitches. For example, today, anyone age 55 or older can contribute an extra $1,000 to their HSA. If you have a married couple and both are 55, they can each do a $1,000 catch-up contribution, but only if there's 2 HSA accounts, one in each spouse's name. Most of the proposed bills sought to eliminate that specific glitch and allow both spouses to contribute an extra $1,000 to the same account. And then generally speaking, at a high level from the Democratic leadership position in Washington, their response to some of these Republican ideas or Republican attempts to repeal these provisions of the ACA, really their rebuttal or their concern has been, are these things merely just tax breaks for the wealthy? If I increase HSA contribution limits, who's going to benefit from that? Is that just the wealthy? Or if I raise the FSA limit, who's going to benefit from that? Is that just the wealthier population? And it appears that Democrats are, at least on the surface, more willing to compromise on changes relative to consumer-driven accounts, provided other Affordable Care Act provisions remain intact. A couple of those provisions being the requirement that health plans cover essential health benefits and the prohibition against denying someone coverage based on their pre-existing medical condition. So if some of those bigger ticket items are preserved, then Democrats may be willing to have some bipartisan conversation with the Republicans on these things. And some of this compromise comes about primarily because of non-discrimination testing rules. These can be a little bit of an administrative headache for employers who offer a cafeteria plan or any of the consumer-driven accounts, where certain non-discrimination tests are supposed to be performed to make sure the plans are not intentionally or unintentionally designed to more favorably benefit highly compensated or key employees. And so there are some specific tests that employers offering these benefits are supposed to perform, and these tests are related to actual eligibility for the consumer-driven accounts, the actual contribution and benefits that go into these accounts, as well as key employee concentration. And if certain testing requirements aren't met, then those highly compensated employees or those key employees either lose or partially lose their ability to participate in the consumer-driven accounts. And so because of these non-discrimination testing requirements that, again, can be a bit of a headache, it actually is opening the door for some compromise that maybe these types of changes won't specifically just benefit the wealthy, and they'll benefit more of the ordinary or rank-and-file employee population. And so, there are some bipartisan talks going on. The success of those is, to be determined. If there is no bipartisan agreement with Democrats and Republicans, then Republicans have a couple of other options that they are considering or they may consider, and that's being something we refer to as piecemeal legislation. This is where they would try to pass a bill really just with Republican support that just focuses on very small parts of the Affordable Care Act, as opposed to trying to repeal and replace very significant or substantial parts of that. And one of those bills that's been introduced by Marco Rubio is the Health Savings Act of 2017, really a bill that primarily focuses on enhancing health savings accounts. And if they don't use piecemeal legislation, or even if they do, they're also onto another agenda item, that being tax reform. And many of the Affordable Care Act tax provisions, such as those that impact consumer-driven accounts, could possibly be included as part of any tax reform bill if that does get indeed passed and signed into law. So if changes do occur, at least the proposed changes that have been out there, this is really going to add what I call fuel to the fire. The growth rates of FSAs and HSAs would be much further accelerated than their current trajectory. Even though their current trajectory is rather high, this would likely have a significant impact on both of those. From an FSA perspective, there'd be a lot more flexibility around plan design and contribution limits. And from a HSA perspective, there would generally be some significant improvements with extra contribution limits and other glitches removed. Right now, the repeal efforts that we see out there, and even things we're seeing on the Democratic side of things that aren't on the repeal side of things, really aren't having any direct focus to the HRA side of things, and nor did the Affordable Care Act when it was originally passed. But HRAs might be indirectly impacted if certain changes within the Affordable Care Act do occur, but we just have to wait and see what those might be, and then how those might indirectly apply to HRAs, most likely through some form of regulatory guidance. And last but not least, everything I focused on to this point has been sort of the healthcare side of consumer-driven accounts. I don't want you to forget about commuter plans. Just very quickly, commuter plans allow employees to make pre-tax payments for expenses, generally transportation-based expenses to get to and from work. There's a mass transportation reimbursement limit of $255 per month, typically things like taking a bus or train to work. For employees that have to pay for parking as an expense to get to and from work, there's also another $255 monthly limit there. I do want to point out that at the end of 2015, there was a law that was passed that now provides for what we call transit parity. Really, the amount that could be reimbursed for mass transportation was about half of what it was for qualified parking. And there would be temporary bills passed every year or every other year that would allow that mass transportation of expense to be the same as that of qualified parking. But then after that 1 or 2 years, it would expire and the mass transportation reimbursement would go back down. Well, now they are permanent, And so the maximum reimbursement for parking and mass transit are one and the same. The newest benefit, I'll call it, is that in some scenarios, ride sharing could qualify as a mass transit expense. And in order to qualify as a mass transit expense, the ride sharing vehicle that picks up the passengers must be considered a van pool vehicle, meaning the vehicle holds 6 passengers plus the driver. And this ride sharing is the pooling type of ride sharing where other passengers may be picked up along the way. The most common examples are Uber Pool and Lyft Line. I do want to point out that they're only available in select cities, and some other circumstances do have to apply so that we can guarantee the appropriate size mass transit vehicle does pick up those passengers. But this is something that is new, again, available in select, typically larger cities, but it is increasing some interest there from employees who take advantage of this type of transportation. I do also want to add at a local perspective that some cities are starting to mandate employers of certain sizes offer a commuter benefit to their employees. Prime examples are the San Francisco Bay Area, New York City, Washington, D.C. Other cities I know are contemplating this, and it is on their legislative radar. So we'll have to see what happens there. That's really most of my presentation, if not all of my presentation for you. So I know many of you have submitted some questions, and Nicole's been trying to respond to many of those for you. But there may be a handful that she was not able to get to. So we're going to try and cover a few of those here today. But in the interim, if you do have questions for us, our contact information and website address is on the screen for you to follow up with us. But Nicole, I'll turn it back to you, and we can see if there's any questions.
Wonderful. Thank you, David. We did have some really good questions come in, so I saved a few because I thought it would be better to have you address them on air so that all of our attendees could hear. One question comes from Marlene, and this refers back to the beginning of the presentation. We were talking about the increasing cost for healthcare, and she wants to know, what are the average premium increases?
Well, it depends on the market segment that we're talking about, but typically in the group health plan setting, you know, the average increase for a group health plan over the last couple of years has been somewhere between 3 to 6%. So much more, I guess, I should say much less than we've seen in other market segments like the individual market segment. But you know, every employer is unique. We know some employers have been lucky enough to have some flat renewals, what I'll call, or not really much of any rate increase from one year to the next, and we have seen others that have had very substantial increases, you know, well into the double digits. So just because we see an average rate increase doesn't necessarily mean that is going to apply across the board.
Okay, thank you. We have another question here from Jamie, and she asks, can you have an FSA without a medical plan?
Well, so in order to have a health FSA, a general purpose FSA, the employees must be offered a medical plan that meets the requirements of the individual mandate, or is also considered minimum essential coverage. They do not have to be enrolled in that medical plan, but they do have to be offered it. Now, there is an exception for limited purpose FSAs. Those are ones that generally just reimburse dental and vision expenses. In those scenarios, employees do not have to be offered or enrolled in a medical plan. And then as it relates to the dependent care FSA, which is, you know, one that's generally used to pay for things like daycare and babysitters or nanny expenses, there is no requirement to be offered or enrolled in a medical plan for that. Okay,
thank you. Another question here from Sarah. With investment options available in HSA accounts, isn't it possible that the employee could lose their HSA contributions due to that risk?
That is absolutely a risk. There is market risk when it comes to investing those dollars. There are many HSA accounts do have you know, money market type of accounts or guaranteed interest-based accounts where you'll earn, a couple of percentage points, but if you do want to put your money into something a little more aggressive like a stock or a bond, there is that market risk where you could most certainly gain money, but you could most certainly lose money. So we usually recommend, and most HSA accounts do have a minimum required cash balance so that there is some money there to pay for medical expenses when need be. But then anything above that, when you have a certain point, those are funds that typically, if you're going to invest those funds, you're able to deal with those fluctuations. But if those fluctuations are a concern, then most certainly if you are going to invest those funds, you want to put those into safer investments where there is minimal to no chance of losing any of those balances.
Okay. Really quickly, because we do have a few questions coming in about the HRCI and SHRM codes for credit, we will follow up with you via email with those codes. So those of you who've been on the webinar until the very end, as long as you've been on for the duration of the webinar, we will send you an email including certificates of completion that have the information for you to file for that credit. So some of you I know have said you need to get off the webinar now. Go ahead. You've satisfied your requirement, and we will be sending you an email within the next 2 to 3 business days with all of that information, how to claim your credit. Okay, just a few more questions here, David. Marlene asks, did I hear correctly, if I do not use my HSA funds for 20 years, I can go back later and seek reimbursement for medical expenses going forward?
Yes, that is correct. So as long as you have not reimbursed yourself tax-free through an HSA or any other account for your out-of-pocket medical expenses, you can essentially bank those receipts. You're really paying for those expenses as incurred with after-tax dollars through a checking account or a savings account. But as long as you keep track of those expenses and you haven't used your HSA or been reimbursed otherwise tax-free for those expenses, you can, let's say over the course of 20 years you had $50,000 in medical expenses, you can reimburse yourself tax-free at any point in the future, whether that be in retirement or otherwise, for in this example, those $50,000 of expenses tax-free. So that's generally different than things like an FSA, where you can only be reimbursed for expenses incurred during the plan year or the coverage period.
Okay, and we have here, looks like our very last question. Where'd it go? Can you give us a citation for the law covering commuter plans?
Well, commuter plans are part of IRS Code Section 132. So if you want to take a look at Code Section 132, that kind of spells out all the parameters about what the obligations are of an employer, what the obligations are of an employee, how to set those plans up. There's some frequently asked questions guidance within there. Again, that's IRS Code Section 132.
Wonderful. Okay, David, thank you so much for your presentation today. I think it was very helpful and informative. Again, for those of you who are looking for the HRCI and SHRM credit, we will follow up with you via email with that information. If you haven't already, in the handout section is a copy of the slides for today's presentation. We'll send a copy in the follow-up email as well, so you can make sure that you have it. And again, if you have any questions or would like more information, please feel free to give us a call, the number on your screen, or visit our website, which again is www.flexiblebenefit.com. Thank you once again for attending today, and we hope you all have a wonderful afternoon.